So I'll be covering in updated heart failure treatment guidelines. You may see a lot of repetition of the previous presentation in this presentation because management is usually the same. But I'll try to cover some of the misconceptions and real place of ARNI right now in the management of heart failure, and are we really using it accordingly or not? That's the disclaimer. Firstly, a definition, still people have a misconception, inability of pump. So it's not just pumping. Heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of ventricle to fill with or eject blood. So it's not just ejection or pumping, it's the filling as well. And that's why if you just look on to the classification of heart failure, you have HFrEF and marginally reduced. And a big chunk of heart failure patients are these HFpEF and marginally reduced ejection fraction. We mainly concentrate on systolic heart failure because predominantly as a class 1 indication is in HFrEF. We do have evidence related to HFpEF and marginally reduced EF as well. We'll cover that. Disease burden, we all know that heart failure is increasing progressively. And with passage of time like 2010, 2015, 2030, you expect that much rise in the prevalence of heart failure because we are saving people with MI. So you expect more and more heart failure, not properly treating them. And that has led to mortality as well. Although these both HFrEF and HFpEF have similar kind of mortality you see at 1 year and 5 year. Almost 29 and 32% at 1 year after diagnosing with symptom, whether it's HFrEF or HFpEF. And at 5 years, it's almost like 65% and 68% respectively for both HFpEF and HFrEF. And then superimposed decompensation, further progressive the course. If you see, if you don't have any deterioration or acute decompensation, the graph is not that very shallow. It's a plateau-like, but once you have a decompensation, it further deteriorates the system and you have more inclination towards increased mortality if you have SOVID. Now coming to the guidelines in relation to ARNI, since there are much more to it nowadays, SGLT2, Vediciget and other, but since we are focusing on ARNI, so that's the journey, starting from digoxin, diuretic, then came ACE, then ARBs, then beta blockers, then ivabradine, then mineralocorticoid receptor antagonist, and then the paradigm HF, ARNI. And so after that, we have a lot more to offer to our patients with heart failure as well. That's important to understand some basics of ARNI, why we use it, how is it different from ACE, ARB. That function of a natriuretic peptide, a lot of benefit effects on the system, both in terms of circulation mediation as well as disease modification. And what you are doing when you're using ARNI, you are taking care of this whole compensatory mechanism by means of two pathways. Not just ARB or renin ACE, now you're taking care of your BNPs as well. By inhibiting that neprilysin, you're trying your natriuretic peptides to keep in system for more periods of time. And that gives you an additional benefit apart from taking care of your RAS blocking. And you can't use it separately. You have to use it with Valsartan combination because that neprilysin inhibitor do inhibit angiotensin II as well. So you have more angiotensin II available in the system if you inhibit just selectively neprilysin. So you have both increase of BNP as well as angiotensin. So that's why you need a combination, and a combination in a very you can say a mechanism be an equilibrium between the two. So that's why you have to use, and certainly when you have a theoretical background that now you are taking two mechanisms, you may get more benefit out of it as compared to just ACE or ARB. That already been told. Now, these fours are not the cornerstone now. They are the main pillars of heart failure management. These four things, and should be started simultaneously, not one before the other. SGLT2, MRA, beta blocker, ACE or ARNI. And the newer things which are coming up, they are suggesting ARNI to be preferred as your first choice in patients with heart failure. And then subsequent adding things, I will conclude these all in my last slide. This is further elaboration in terms of ejection fraction. All those four are there. And then diuretic according to your patient's volume status. Whether you need it or not, it all depends on whether your patient is euvolemic, hypovolemic, or hypovolemic. Otherwise, these four drugs should be there in every patient of heart. ACE, ARNI, beta blocker, MRA, and SGLT2. Now, if you discuss something about marginally reduced EF, we don't have any class 1 indication drugs there. But we have class 2B, ACE, ARB, beta blocker, MRA, and ARNI. And now SGLT2 are also coming in that arena after Emperor Preserve trial. And that's the criteria for diagnosing heart failure with preserve ejection. EF greater than 50% symptoms, and some objective evidence of cardiac structural problems by means of either echocardiography or raised BNP levels. Similarly, HFpEF, no categoric classical treatment. If volume overload or congested, you can give diuretics. Otherwise, you offer again as a 2A, 2B, all these drugs like beta blockers, taking care of risk factors and all that. In terms of cardiology expert consensus decision pathway, that's the most latest, and they suggest ARNI is the preferred renin-angiotensin in HFrEF. In the absence of all other issues, a direct to ARNI approach is now recommended, close follow-up with, and subsequently seeing all the things, whether anything which can obstruct its further treatment strategy, any contraindication as such. That's the last 2-3 slides in relation to the latest 2022 guidelines of AHA. Stages now A, B, C have given some labels. Stage at risk of heart failure, B, pre-heart failure, C, symptomatic heart failure, and D, advanced heart failure. And stage C then further classified according to the presentation: new onset heart failure, resolution of symptoms, persistent heart failure, worsening heart failure. So heart failure needs a very close assessment to know where your patient is in terms of his clinical status. In terms of classification, AHA has slightly added one more thing in that, which is HFpEF. HFpEF is a patient who's have reduced EF and that he has recovered. Rest of the classification are there. So you may get some patients like cardiomyopathies, myocarditis, decrease, consequently they improve. So this is one more addition to that. And that's the last slide, very busy, again giving you further more things about it. And these are all just the repetition which Dr. Shahbaz told about. You can offer a lot of more things according to the patient status. Atrial fibrillation, mitral valve regurgitation, whatever you can add. Heart rate is fast, ivabradine and all other. But main pillars are those four management strategy. So if we just conclude the question we started, ARNI in updated heart failure treatment guidelines, you can go through this slide, that these four pillars of heart failure management should be there. And ARNI is now recommended as first line RAS to reduce morbidity and mortality in HFrEF patient. In HFpEF and marginally reduced, it's a 2A or 2B. Thank you very much for your patience listening.